Welcome to another episode of Stories from the Edge of Life. We once again have a very special guest, Dr. Stephen Norris. Dr. Norris, would you mind introducing yourself to our audience?
Hi, my name is Stephen Norris. I'm a practicing internist in Amarillo, Texas, USA. I've been in private practice now for almost 18 years, and I have known you, Parag, for since our residency days, so a long time. And I'm honored to be here today.
Thank you. The honor is all ours. And thanks for making the time. I know you're very busy. And I am Parag Bharadwaj. I'm a palliative care physician in the US. So, Dr. Norris, we've had many discussions over the years in terms of changing perspective about what patients really go through and reflect on life lessons from those experiences. Would you mind sharing with our audience how as a physician, your outlook on patient care might have changed as you witness how they go through their experiences as patients and caregivers?
Sure, absolutely. I'd love to. I've been in practice for almost 18 years now and doing primary care medicine. I've had an opportunity to become very acquainted with my patients. Many of them have seen me since the onset of my career. And in that, I've gotten to the opportunity to know about their families, their children and grandchildren. And in that, you experience life with them. And it's hard not to become familiar with them. And many of my patients are my friends, they're my family. Not literally my family, but they become like family. And when you see them face these challenges in life, it's hard not to reflect. I think it's necessary to reflect on the impact that they have on not just their lives and their loved ones, but my life. To say that I would go through this and not be affected by their stories is would be callous. It would not be true. And I want to offer compassionate medicine, and that's one of the things that I've come to know through our relationship is that there is suffering in this world, and I think that in that it's important to see these stories and to empathize and to learn, and then to see how we can apply those things to our own lives.
Absolutely. And you're right. The physician-patient relationship is very sacred, as from our point of view, and I'm sure with other
Absolutely.
physicians as well. And you want to maintain that boundary and respect, their privacy as well. But I've also come across experiences with some families let you in more than others. And sometimes you realize after the patient's demise. I actually had a patient once where took care of the patient for weeks on hospice. And the day the patient died, I actually happened not to be caring for the patient. I was
Mm.
off. And the remark the family made to the staff was, "It's a good thing that I wasn't there. Otherwise, they thought I would have taken it pretty heavily.
Uh-huh.
It I might not have dealt with the situation as well as they did. I mean, that's how close they thought I was to the patient.
Hmm.
So yeah, I really appreciated what I heard from them, and yeah, you're right. Sometimes they become family, and if not from your perspective, from their perspective.
Absolutely.
So, would you mind sharing with us a few experiences that you've come across, or like any particular patient scenario that comes to mind when we talk about such experiences?
Sure. One of the things that I find that patients oftentimes dealing in chronic care is just chronic illness. And it brings to mind a particular story of a patient who had been morbidly obese, and she decided to pursue bariatric surgery as a weight loss option. And through really no fault of anyone, the surgery was, I would tell you, just deemed too successful. She became in a chronic state of malnourishment. And in that, she started to have her physical appearance change, not just by weight loss, but because of her poor nutrition. Her teeth began to fail. She had multiple dental caries. And after an ER visit, uh, the ER staff deemed just through observation, through no direct proof, that she was obviously a methamphetamine abuser. And so, knowing that she had children at home, they contacted CPS, and this patient had a visit from Child Protective Services. And through no fault of her own, her children were taken from her for a period of time. And after she went through multiple rounds of counseling, multiple rounds of drug testing, all of which were negative, by the way, except for any prescription medications. She did finally, receive her children back. But this woman continued to have failing health, and she came to see me after surgery, after she had already had lost her children and was in the process of, getting them back, and she was miserable. And the surgeons had told her that in essence there was nothing more that they could do for her, that her condition was terminal. So after we discussed that, we thought, quality of life is important. And with my experience with hospice, I said, maybe this is time to transition to hospice care. And so that's exactly what we did. We got her enrolled with a home hospice program here in town, and they began to take care of her. I was still seeing her as her primary care physician. And in this, what we didn't realize, her symptoms seemed to be related to nausea and vomiting and lack of being able to tolerate any foods. But what had not been communicated and what had not been addressed was this underlying pain that she had from her surgery. And one of the amazing things that happened in hospice care was that her pain was addressed. And I think that it had been poorly communicated because I think oftentimes when people deal with a situation, the body can change their symptoms to become something different. That sometimes pain can present as anxiousness, especially see this in Alzheimer's patients. I had a patient in just the other week or a couple of weeks ago who had a fall or I was actually in a car wreck and fractured ribs and his sternum. And his wife had talked about how he was more agitated and anxious, and he would just punch the furniture, or things like this. And we discussed that this is likely, a symptom of his pain coming through. So that's something we wanted to address. And in this patient, we kind of started to think that maybe her nausea was related to this underlying pain that she was finally able to discuss. And I think there was also this stigma that she had this fear that that if there were any question of abusing medication, she would lose her children again. And she had preteen children. And as a mother, it was her ultimate duty to just be able to be there for her kids. Her heart's desire was to see her children grow up and become adults and to be married and to become successful in life. And this was, potentially being stolen from her. But once she was in hospice care, they were able to address these concerns with her, put her on appropriate medication, and amazingly enough, her situation turned around dramatically. She stopped her weight loss, was able to start maintaining. She actually started to thrive to the point that she graduated hospice. And so it was at this point we realized that it wasn't hospice she needed, that this didn't have to be a terminal condition. What she really needed was palliation. And in that, what I saw was a woman who, for the sake of preservation of her family, was enduring tremendous pain, and was doing so out of fear, out of, I think, of a societal misunderstanding of what suffering is, about how it should be managed. We live in this time here in the United States where pain relief has become an evil thing. That any amount of abuse all of a sudden starts to taint that access to medication to patients who actually need this. And to see someone who was willing to just suffer to the point of death just to be able to maintain her family, I think is a testament to a mother's love and to the strength of the human spirit, what we're able to endure. And it's been amazing to see in this patient's life, now that she's able to have adequate pain control, how much better her symptoms are, how much quality of life she has, and not just quality, but quantity. This woman is continuing to maintain her weight. Her health is not stellar, but it's definitely not lessening. And in that, she's able to be there for her children. She's able to experience life with them, to see them now as teenagers, to see them growing up and on their way to becoming adults. And as it stands right now, we have no reason to believe that she won't see them enter adulthood. And I think that that's a testament to the power of again, the human spirit and what people can endure, and the power of what being able to communicate and address these chronic health issues in a meaningful manner, the difference it can make in someone's life.
Yeah, it seems like the underlying pain was causing a lot of suffering on a lot of different aspects of her life.
Absolutely. Absolutely.
So that's a great, you've experience you've had with the patient. Just for the sake of our audience, so she started off opting for bariatric surgery. Could you explain what that is and what was the indication for it?
So this is a person who was morbidly obese. She was in excess of 350 pounds. And so with bariatric surgery, she had a procedure, a gastric bypass, where they rerouted her intestines to where it would create a mildly malnourished state. So she would not be able to absorb calories and nutrients from her food, which would help her lose weight. In that, it reduces the size, the effective size of the stomach, so that her food intake would uh, what would what would fill her stomach would typically be slightly larger than a golf ball. A food bolus slightly larger than a golf ball.
Got it. So she started out doing this for health reasons,
Correct.
right? And it
Hmm.
almost took her life.
Absolutely.
So wanting to live longer was the intent. And then I mean, how ironic is this whole experience, right? And then she goes through this procedure. She ends up on hospice
Hmm.
for end of life care.
Yes.
And then they manage her pain and they bring her back.
Absolutely. And she's now at a healthy weight. So she's down over her weight's right at 130, 140 pounds. So she's lost over 200 pounds, which is just a tremendous amount of weight loss. And her health, in some ways, was improved by this. But again, this almost cost her life and created tremendous suffering. Um, I haven't asked her, but you wonder if they had it to do over again, if they would make the same choice. I can almost guarantee her answer would be no, she would not.
Got it. Yeah, it's the unintended consequences, right?
Absolutely.
Now, the other interesting aspect of this whole experience that you've had with the patient was how she was labeled, right,
Hmm.
as a drug abuser or drug addict, and she just wasn't fitting the box, right? And
Absolutely. Simply because of her looks, because of her
yeah,
dentition. In methamphetamine abusers, it's not uncommon because of their diet that they have very poor dentition. And nursing staff just assumed, based on her looks, they prejudged her and labeled her as a drug abuser when there was no founding basis for this whatsoever. Truly a travesty.
right. And I'm sure I mean I can speak for myself. I've also jumped to conclusions looking at people based on their appearances, but then
Hmm.
I think the key is to have a conversation to figure out,
Absolutely.
what's really going on, and then you often get a very different picture of the whole story behind, the appearance.
Absolutely. One of the most powerful tools that we have at our disposal in medicine is the power of observation. Your first part of your examination is just looking at someone, and you do that from the moment that you walk in the room with them. And based on that, through training, we do have a prejudgment. But I think that the important part is that's part of a differential. It's a possibility, and there are other things that need to be investigated to be able to determine the veracity of that. And I think that that's where this fell short in this patient's case.
And you're absolutely right. As you was, sharing your thoughts, that's how we are trained, right, as doctors. If you see something, then this is what it's most likely to be.
Absolutely.
But you're right, it's also a differential. We got to confirm it.
Hmm.
Great. Awesome. So I'm so glad to hear that the patient is doing well and under your care. What else comes to mind? Anything else from that particular experience, or do you have any other experience to share with us?
Yeah, I've got another experience. I just had a visit with a patient here recently, someone that I've been taking care of now for probably 17 years, and I have multiple family members of theirs that I take care of. And this gentleman came to see me several months ago with terrible back pain, and so we started the process of investigating his pain. In that process, we discovered that he had lytic lesions, or areas of his bone that were being eaten away. And the differential for that includes cancers of various types. And through biopsy, we were able to determine that he had metastatic prostate cancer that had spread throughout his body. So we immediately got him plugged in with an oncologist, and very quickly he was enrolled in their palliative care program, and started receiving uh, treatment for his prostate cancer and then palliation. And um, it was a little while to get everything adjusted, but we started to finally make headway. And I saw him this week, and he'd had a bone scan done by his oncologist, looking at these lesions to see if there were any more or anything like that. And he had not received the results from his oncologist yet, but they asked me to relay those to them. And so we had a conversation, and his cancer burden is extensive. It seems to be all over his body. There were lesions that were noted in his shoulder blades, in his collarbones, all of his ribs, his breastbone, his sternum, multiple areas along his spine, in his pelvis, and in his femurs. Pretty much almost everywhere they looked at, they could see evidence of cancer in his bones. And as I'm relaying this news, I'm looking at him and his wife starts to tear up, and he gets a look that I call the kick in the gut look. When someone gets hit in the stomach, they lose their breath, and it's almost like they can't breathe for a minute, and their eyes get this look. And he said, "So is it bad?" That was his question. And at that moment, we had to transition from the medical aspect of this to the humanity side of this. This is a person that I've formed a relationship. He and his wife will tell me that they love me when they leave my office. Their family loves me. They constantly are so appreciative of our relationship, not just the care that I render, but their relationship that we've formed together. And I knew that I had to address that. And so I asked him a simple question: "How do you feel right now?" And he thought about it, and he says, "I feel fine." And I said, "Okay, but how do you feel right now?" I said, "Do you feel good? Do you feel bad? Do you hurt? Are you having any problems?" And he says, "No, I feel good." And I said, What did you do? What did you do this morning before you came to my office this afternoon?" He said, "Well, I went to coffee with my friends, and then my wife and I had lunch." And I said, "Okay, so you're living life." I said, "This test is just a test. You know, is it what we want to see? Would we rather see that there's nothing there at all? Absolutely. But at the end of the day, this test does not dictate who you are. It doesn't dictate how your life is going or what your outcome is going to be." And um, in that, he and his wife started to share. They said, "Honestly, since I've received this diagnosis of cancer, it has really brought me so close to my family. My kids are there to see me every chance. I've had two grandchildren who have been born in the last 6 or 8 months, whatever it was. I've been able to go to two family reunions and see relatives that I haven't seen in years." And he said, "I've just had so many opportunities to become closer to my family." And his wife said, they've been married for almost 60 years. And she relayed the fact that um, through this, they've really rekindled their love in their marriage. They value each day for what it is, that each day is just, we call it the present, and it's a gift. It may be the now, but it really is a gift that we're never really guaranteed anything beyond this second. No one knows the future. And in that, they started to live in the moment. And one of the neat things was they talked about one of their favorite things to do is they have a patio at their home, a little side courtyard where they like to go out and enjoy time together, looking at the sun, enjoying the weather, sunsets, rainstorms, having coffee, just being outside together in that moment. And it's become one of their treasured times. And after literally a lifetime together, that seems to be one of the things that they enjoy the most. And in the scheme of their marriage, in the scheme of 60 years of life together, all the ups and downs, all the things that they've done, this is becoming one of their most memorable. And so in that, I think that we as physicians, we're all always looking for this grand scheme of things, this bigger scale. We look at quality of life, and it's about packing it as full of every opportunity and um, every experience that we can. And for some of us, we would have the bucket list, these things that you would like to accomplish, this bucket of things that you would like to accomplish before your life is complete. And for many people, if you've ever seen the movie Bucket List, it's going skydiving and experiencing these once in a lifetime events. But I think that sometimes those are not always the most meaningful. That it's the little things that count. It's this time that they spend just together, sitting in a chair on a patio beside their house. They're not in an exotic location. They're not surrounded by exotic people. They're not doing exciting and adventurous things. They're simply having coffee. They're having a conversation. They're in the moment in love. And I think that's one of those things that oftentimes we take for granted, that it's not always these big events that people end up cherishing the most. It's the small things, and even in patients who have experienced loss, if they've lost a spouse or a loved one, I always try to warn them. Your first year, the big events are always going to be the hardest. Your grief is going to be the strongest then. Birthdays and holidays and anniversaries, those are going to be hard times because your memory will be very vivid during that time. But oftentimes patients, they find it's the littlest moments that seem to be the most impactful. That it's when they lay down in bed at night and they don't hear their spouse breathing. Simple breathing. It's not a conversation. It's not, a touch, or it's the warmth in bed next to them. And I think that it's easy in life today to overlook the small things. And sometimes those can be the most meaningful, the most cherished, the most impactful in someone's life. And they should hold equal, if not, the most importance when we try to deal with that. And I think that one of the things that I've learned in my career is that the medicine part of my job honestly becomes relatively easy. I see similar things day after day. I've become accustomed to how to treat those. That's not to say that I'm, inviting challenges. I always enjoy a challenge, but I don't want that for my patient. But the medicine part is easy. The humanity part is not. Trying to reach in and give that compassionate care, to give that to let patients know that they are truly being cared for, not just being provided with care, but being cared for, to provide them with empathy and sympathy, is always a challenge. And I think that again, in life in general, we tend to get caught up in these big moments. You look back at the things that are most impactful in our lives, and they're usually, births and deaths and marriages and amazing vacations or traumatic events. But oftentimes in our day to day, those are not the most common things, and it's truly the most common things that I think have the biggest impact on people at the end of their life.
Wow. Yeah, you mentioned a few things that really caught my attention. One was you mentioned exotic people. Uh, while these people are not exotic, they are their own. They're ones that they
Absolutely.
have a connection with. And most of the things that you describe actually, uh, patients valuing, when it comes to their experiences, involves another person, and that is usually a loved one,
Absolutely.
right? And so it's not the location; it's who you're with. Seems to be the theme
That's right.
that
It's
I'm
not,
picking up.
being surrounded by celebrity. It's not being, pampered by, the most important people in the world. It's just those who are close to you and love you.
Right. And then the other interesting thing you mentioned was this patient was going through treatments while the patient was on palliative care. So,
Mhm.
yeah, you can get that when you're being cared for by palliative care, because I think the concept of palliative care is a little bit different in different countries. And at
Yes,
least here in the US, we're lucky that, patients can get access to palliative care, receive comfort, and so that they can experience the best life they can by
absolutely.
themselves and with their loved ones.
And I think that, here in the United States, we differentiate hospice care, end of life care from palliative care, which is that comfort care. And I think that even here, there's still a lot of misconception. I think that if you ask, the average person who knew what palliative care was at all, they would assume that it was just part of hospice care, and they're oftentimes used in the same phrase, hospice and palliative care. And I think that it's important to be able to distinguish those between the two. That, a simple surgical procedure can, present someone with suffering. And if we can alleviate that suffering through whatever means, whether that's medications or physical therapy or other modalities, including, spiritual care for these people, then that's what palliative care amounts to. That it's that goal to eliminate suffering. And in that, when you eliminate that suffering, oftentimes people find quality of life. And that's what I think at the end is most important. One of the things that I tell my patients all the time, whether you're 8 or 88, quality of life should be important to you. We can do a lot of things to keep people alive in this day and age. And sometimes it's at their suffering. And that's not always the way to do things. And so I think that that's important to differentiate between the two, is that quality of life is going to be important. And I think that palliative care is under recognized, in its ability to help people achieve that.
Well, of course, you might think I'm biased, but I agree with everything that you said about palliative care.
I thought you might.
And I think that that would be a perfect way to end this interview. I do appreciate very much your time and your contribution to Palliative Care Network over the years, and you've been a great supporter of ensuring we get the right help and support to clinicians around the world. So I just wanted to thank you for all the
Well,
efforts.
it's been an honor to be with you today, and as my friend, I would do anything for you, and I'm always happy to further the cause.
Thank you very much. We'll see you again soon.
Thank you.
Did you like this story? If so, please subscribe to this channel and like and share the video. Want more? Buy the book, Stories from the Edge of Life, available now on Amazon for more stories like this. All proceeds support Palliative Care Network, a nonprofit dedicated to alleviating suffering and improving the quality of life for patients facing end-of-life issues. Consider extending your contribution by donating through the link below. Thank you for your support.